All right. Good evening, everyone. Why have I gone to ENT? Yes. Good evening, everyone. I hope you still are awake, everyone. And my session was one session before, but my house internet, I don't know, disrupted for 10 minutes. I have to rush and come to the studio. Hi, everyone. Hello, everyone. So during the Dr. Gaurav Patel's class, I told that I also want to go to Miami. My internet connection said, first go to studio, then you go to Miami. Okay, doesn't matter. Let us, good evening, everyone. Let us quickly see some quick review. And by quick, I mean really quick, because I know you all are tired. Let us spend, everyone says 30 minutes, but they don't take 30 minutes. They take a lot of time. But I will try to, 30 to 40 minutes, I'll try to complete it. So we will do a rapid revision with the most known topics, with high yield topics in this ophthalmology session. Okay? So without wasting any of the time, let us start. Topic wise I have divided. Let us start with ocular injuries. I expect at least one question from ocular injuries in this coming NEET. You have to divide the ocular injuries into closed globe and open globe injuries. Example of closed globe injuries will be blunt trauma. Okay? Many questions have come on blunt trauma, but this is an important topic. Lately, they have started asking question on this. This is a picture, you know. This is penetrating trauma. The question which they ask is what you do immediately, perforation repair as soon as possible in the operation theatre, not in OPD. Okay, and the removal of toxic foreign bodies have to be done, like iron, copper, mercury, and the repair of corneal sclera has to be done. This much is important for penetrating trauma. But the question which I am expecting is blunt trauma. Blunt trauma, which is a fracture of the orbit in posterior middle wall of the floor. That is maxillary wall fracture. Just a sec, please. All right. There's a maxillary wall fracture, and that will lead to floor fracture known as blowout fracture. You know, the teardrop sign comes. If someone punches you, eyeball goes inside, N ophthalmos. Infraorbital nerve anesthesia, and which muscle can be entrapped? Inferior rectus, inferior oblique, most common inferior rectus, and it is a restrictive. So patient will have problem in elevation of the eyes, difficulty in elevation, not depression. Okay, and forced duction test will be positive. Remember these points for blunt trauma. Other quick points of blunt trauma. What is this? Is ecchymosis, subconjunctival hemorrhage. Nothing to be done for subconjunctival hemorrhage. Hyphema, right? D-shaped pupil, that is known as iridodialysis. Washious ring, very important sign. Washious ring, rosette cataract, and cherry red spot, Berlin's edema. Which layer of the retina is involved here? The ganglionic layer is involved here. Ganglionic layer edema is there. What is this? Important picture. A repeat question, but this can be asked. Looking like a panda sign or a raccoon sign. This is basal skull fracture of which cranial fossa? That is important. Remember, only quick point, anterior cranial fossa. So these blunt trauma points are very important. But one more blunt trauma point we have to remember over this. This is an open globe injury, but this can also happen via blunt trauma. So blunt trauma always does not cause a closed globe injuries. Blunt trauma, if the force increases, it can rupture the eyeball as well. This is known as a globe rupture. So globe rupture is a sign of open globe, not a closed globe. Remember that. Okay. Second, let us see some quick points regarding embryology. Remnant of the hyaloid vessel. Hyaloid vessel joins the optic disc to the lens. Entire hyaloid vessel persistent hypoplastic primary vitreous. Poor prognosis. Patient child will have a lot of symptoms like retina detachment, like posterior polar cataract, like vitreous hemorrhage, most common. But if only the anterior portion persists of the hyaloid vessel, that is Mittendorf dot. If the posterior persists on the optic disc is papilla, Burgmeister papilla. Remember these hyaloid vessel remnant, 3 remnants I have told you. Important one, PH, PV. Closure of the embryonic fissure, coloboma. Question can be asked on this. This is iris coloboma, eyelid coloboma. Most of the coloboma is inferior nasal. Can be anywhere. Most common coloboma, inferior nasal, lens coloboma. This picture is very rare, optic disc coloboma. It can happen anywhere. This is an important picture for you. Iris coloboma, failure of closure of embryonic fissure. All right. Important quick points regarding lens. All right. clinical questions are going to be asked. Okay, clinical questions going to be asked. For example, a patient comes to you and he developed cataract and he developed increase in the minus power, increase in the myopia. When there is a central refractive index increases, what happens? The ray of light converges and patient has induced myopia. Answer would have been nuclear sclerosis. So patient having -4 number, he develops -7 number. There is development of cataract. Which cataract? Nuclear sclerosis, nuclear cataract. That is, and near vision improves, second sight phenomena. One clinical scenario regarding nuclear sclerosis. Second important clinical scenario, a patient of cataract complains of glare at night while driving. A very important and very easy cataract, posterior subcapsular cataract, also known as cupuliform cataract. Cataract surgery complications is second question which I am telling you after ocular injuries can come as a question. After cataract surgery, there is a shallow entry chamber. It can be due to low IOP or high IOP. If there is shallow entry chamber and low IOP, there is a wound leak, and wound leak can be detected on this fluorescein test known as Seidel test. So Seidel test positive means there is a wound leak incision and the IOP is low, entry chamber is shallow, you have to repair it. If the entry chamber is shallow and the IOP is high, three differentials. Pupil block glaucoma, iris Bombay, do laser iridotomy. Iris lens diaphragm comes up when the aqueous goes to the vitreous, it pushes the iris lens diaphragm up. Malignant or aqueous misdirection glaucoma. As the name suggests, aqueous goes into the vitreous. Laser hyalodotomy or vitrectomy. And third differential, suprachoroidal hemorrhage. It is an intraoperative complication but continues as postoperative. Short, long posterior ciliary artery can rupture in the suprachoroidal space. It lifts, it pushes all the intraocular contents out of the incision. That is suprachoroidal hemorrhage. Another differential of high IOP with shallow entry chamber. Low IOP, only one differential I have given, wound leaks. Vision loss, again another complication, cataract surgery. Patient after cataract surgery comes with vision loss, haze in the cornea, intraocular inflammation after cataract surgery. Two important differentials, and you have to differentiate between TAS, toxic anterior chamber syndrome, and acute postoperative endophthalmitis. If the patient timing within 24 hours present, then it is TAS. Endophthalmitis 3 to 5 days classically after cataract surgery. Symptoms are less in TAS, symptoms are more in, pain is more in endophthalmitis. Most common organism, staph epidermidis. Chronic endophthalmitis after 1 month can also occur, mild symptoms, propionibacterium acne. But this timing is very important, less than 24 hours. Limbal to limbal corneal haze in TAS. Limbal to limbal corneal haze in TAS, here it is localized. But limbal to limbal painless condition within 24 hours, it is due to the IOL material. Congestion is also less. Posterior segment is normal because it is only anterior chamber syndrome. Here the posterior chamber will have, the posterior segment will have vitritis. That is the definition of endophthalmitis. Only gives steroids over here. Here you have to give antibiotics. Intravitreal antibiotics, ceftazidime and vancomycin. But there is a study, if the vision of this patient, remember this point, if the vision of the patient presenting vision is less than hand movements, you have to do vitrectomy, pars plana vitrectomy. If the vision is better than hand movements, then intravitreal antibiotics, ceftazidime, vancomycin. So remember this, postoperative complication. Most common postoperative complication after cataract surgery, years after cataract surgery. And again the patient presents with glare at night while driving. This is after cataract surgery. Before cataract surgery, it was the cataract, posterior subcapsular cataract. After cataract surgery, the patient presents the most common complication, posterior capsular opacification, also known as Elching, pearls, Sommering rings. What do you do? Laser iridotomy. Laser iridotomy has to be done, right? Next, congenital cataract. Most common congenital cataract is blue dot. Nothing to be done for blue dot, but zonular cataract will cause loss of vision. So for congenital cataract, you have to operate, lens aspiration has to be done, like phacoemulsification. Along with that, posterior capsular excess, because that will lead to posterior capsular opacification in child. So nikal do बांस ना बजेगा, ठीक है? Plus anterior vitrectomy also, because that helps in formation of posterior capsular opacification, and intraocular lens has to be put. This is the complete management of congenital cataract. Intraocular lens which you put is under corrected. under correction of intraocular lens is done of congenital cataract. Remember this point. And what do you give after cataract surgery in adults, even in children? You give near glasses because accommodation is lost. In child particularly you give bifocals. Above segment for far maybe zero power, but near glasses are given, the plus glasses for the near segment. Horizontal line glasses is executive bifocals, especially for pediatric pseudophakia, aphakia. See this child, this is having some, this is congenital cataract, most common cause of leukocoria. After cataract surgery accommodation is lost, so near glasses are given. In child, bifocals are given. You give him bifocals, the child becomes happy. So bifocals, executive bifocals. One more indication of executive bifocals in children is very important. This is, if the child has more accommodation, eye comes inside. Accommodative esotropia. Eye goes inside. Esotropia means eye inside. Here you want to assist accommodation in the child. So assisting accommodation again by near glasses. You give glasses to the child, he becomes happy. So two indications important for pediatric executive bifocals. Yes. Yeah, good Ketu and Ashrit. Subluxated lens. Many questions have been come subluxated lens. Easy topic. Remember the causes. Maths हमारी अच्छी है. Remember my maths. Marfan's syndrome, aniridia, trauma. In Marfan's, subluxation is supratemporal. Exactly opposite, homocystinuria, inferonasal. Remember, homocystinuria, Marfan's both have Marfanite hepatus. Tall, long arms. Difference is, in Marfan's, the zonules are intact. Homocystinuria, zonules are also lost. And subluxation is inferonasal, subluxation is supratemporal. Both have Marfanite hepatus. They will confuse you. Don't get confused. Retina is a Pandora box. Let us see what you want to learn. Retina layers have to be learned. If I want to choose one layer for you, you choose this layer, which is coming from internal limiting to external limiting. See this. This is Muller cells. Muller cells nucleus are in the inner nuclear layer, but it spans from ILM to ELM. So remember this as an important and animated picture. In the histopath picture also they can ask. From the vitreous to the retinal pigment epithelium. Pigment epithelium means there is a brownish. Ganglionic cells, remember this, the cellular layer. Inner nuclear layer. Outer nuclear layer. Inner towards the vitreous, outer towards the vessels. Vessels are choroid, sclera afterwards. Between the cells there is plexiform, synapse. Inner plexiform layer, outer plexiform layer. This plexiform layer, remember as important point. So I am not going to detail in this. Remember retinal histology to be learned, even in animated picture and histology. Based on the layers, we have optical coherence tomography. But the important point, all the retina has 10 layers, but the central retina has less layers. Fovea has about 5 layers. Fovea has one extra layer, Henle's layer. That is why in optical coherence tomography, there is a dip in the normal retina. This is again from vitreous to the sclera. This is blackish vitreous, 10 layers of the retina, but fovea has less layers. Red line is the retinal pigment epithelium, then choroid, then sclera. Let us see what OCT pictures you want to know. It tells about central retina. Central retina there is a hole. Macula there is a hole. Answer is macular hole. Idiopathic condition. Do pars plana vitrectomy. Macular edema. Thickness of the retina is increased. Cystoid macular edema. Various conditions. Drugs important. Niacin. Prostaglandins. Adrenaline. Diabetic macular edema. Pseudophakic macular edema. Venous occlusion macular edema. Treat according to the cause. The 10 layers of the retina are detached. Pigment epithelium detachment, a feature of age-related macular degeneration. Remember this differentiation form? The 9 layers are detached. This is retina detachment. And the serous fluid is coming from the retina, from the choroid, serous fluid is coming from the choroid. Central retina is detached, central serous retinopathy. Young male coming to you with metamorphosia, central vision loss, central serous retinopathy because of outer barrier break. That is what we are going to see in the blood supply as well. Blood supply of the retina, the inner 6 layers of the retina supplied by CRA, outer 4 by ciliary, which is a part of choroidal circulation, which is both are branches of ophthalmic artery, internal carotid artery. So what you do? There is a inner barrier. Between the blood and the retina, there is a barrier. Inner barrier is formed by retina vesicles endothelium catering to the inner 6 layers. While the outer barrier is the retinal pigment epithelium catering to the choroidal barrier, which does not allow the choroid blood to go to the retina. Based on this, what is the investigation? Angiography. This is the right retina. Angiography, the vessels have dye. That's why it is angiography. Why the dye is not coming out? Because of barriers inner and outer. Where is the dye put? Dye put in antecubital vein. It goes to heart, it goes to ICA, ophthalmic artery, CRA, ciliary circulation, but does not come out of the vessels because of the barriers. What happens when it comes out of the vessels? Like see, dots. This is the first sign of diabetic retinopathy. Remember, microaneurysms. Nothing to be done. Mild NPDR, nothing to be done. Ink blot appearance, that is central serous retinopathy. Young male metamorphosia. Cystoid macular edema, seen in the late stages of angiography. Flower petal appearance, the causes which I told you. This is microaneurysms, dots, that is very mild NPDR. Okay, important question. In diabetic retinopathy, you can see this is the right retina. These are the hyperfluorescence black marks. This is hyperfluorescence, dye is leaking. Why the dye is leaking? Dye is leaking because of ischemic areas, hypoxic areas produce VEGF. VEGF causes new vessels to leak. The dye is leaking. This is new vessels elsewhere because of hypoxic dark areas, hypofluorescence hypoxic areas. VEGF is produced. This is proliferative diabetic retinopathy. If the dye comes into vitreous, it blocks the entire view of the retina. This is vitreous hemorrhage. That is hypofluorescence. Nothing can be seen in the retina. This is also proliferative diabetic retinopathy. What do you do for this PDR? Pan-retinal photocoagulation is a primary treatment. Anti-VEGF injections, secondary treatment. Remember anti-VEGF injections? A new one, broclizumab. Other previous ones, aflibercept, ranibizumab, bevacizumab. But the new one, remember, broclizumab. What do you do by vitreous hemorrhage? Wait for 3 months. After that, take out the vitreous, pars plana vitrectomy. What is the differentiation between the two? One is, you can see all the 4 quadrants have retina hemorrhages, tortuous dilated veins like a tomato splash appearance, CRVO. But here there is a cherry red spot because of ganglionic edema. This is CRAO. CRVO, also pan-retinal photocoagulation has to be done. Retina detachment question, rhegmatogenous retinal detachment is a third question which I am seeing can come after ocular injuries. Second, I told you one question. I told you after ocular injuries. One more I told you now. And this is the third question which I am telling you, a clinical question which is going to come. Rhegmatogenous particularly, a patient comes with floaters, flashes, and a curtain falling from above or below. That is rhegmatogenous detachment. Traction mostly seen in diabetic when there is new vessels pulling the retina up. You have to do an exudative. The example was central serous retinopathy. Many examples. One remember central serous retinopathy. Treat the underlying condition in exudative. Do vitreoretinal surgery in the rhegmatogenous and tractional. What do you do in vitreoretinal surgery? Simple steps. Take out the entire vitreous, pars plana vitrectomy. See, there is a hole. This is rhegmatogenous. Fill the vitreous with silicone oil or gas and close the hole with the help of laser. 3 steps. Take out the vitreous, replace the vitreous by silicone oil or gas. Gas can be air, SF6, C3F8, and do laser around the hole. So it is a rhegmatogenous detachment. 3 simple steps. In tractional, there is no hole, so just 2 steps. Take out the vitreous, replace the vitreous. What is the complication of silicone oil? Hyperoleon. It goes up. Hyperoleon is a complication of silicone oil. Good. Age-related macular degeneration. There are drusen's deposited in the macula. Macula means central retina. This is left retina. Drusen's are deposited in the macular area. They are end products. It can push all the 10 layers up. That is pigment epithelium detachment. It is deposited in the Brooks membrane. 90% patients have dry AMD, only drusen's are there. But if choroid vessels now come into the retina, that will lead to wet ARMD. 10% patients will have choroidal new vessels. 90% will have dry. Antioxidants, low vision aids for dry. That's it. Choroidal new vessels, you have to give anti-VEGF injections, photodynamic therapy. Another question which I am saying, Photodynamic therapy, wavelength of photodynamic therapy 689 nanometers. Remember this. This can come. Retinitis pigmentosa is an important question. Don't miss this retinitis pigmentosa. It is seen in a young patient. Night blindness and 3 classical signs: arteriolar attenuation, waxy dyspallor, and the bony spicules. Electroretinogram is an early investigation which is decreased. Particularly A wave of ERG is decreased first. Alright. 2 dystrophies which are important and you can remember like this. लड़का है, लड़की है. लड़की देखो छोटी सी चोट लगी है and she is crying and so many daggers are there in the male and still he is saying sorry. This happens in real life and this happens in Stargardt's and BEST. Means the symptoms are more in the girl, signs are less. Symptoms are more in Stargardt, signs are less. Opposite BEST, symptoms are less, vision is normal, signs are more. Remember the sign, egg yolk appearance. Early stage. But later stage, this is lipofuscin deposit. Later stage, this egg yolk disrupts, leading to scrambled egg appearance. That is also looking like a pseudo hypopyon because hypopyon occurs in anterior chamber. So signs more, symptoms less. Opposite, vision is poor, symptom is more, sign is less. This picture cannot come because sign is less. But we have to remember is Bull's maculopathy, retina flex can be seen in Stargardt's. So young patient coming with vision poor, retina seems normal, and there is dark choroid on angiography. Remember that. That's a repeat question. That is Stargardt's disease. Autosomal recessive, BEST, autosomal dominant. Same thing, girl and boy scenario occurs in this. Cornea ulcer. What is that? A farmer comes with trauma with vegetable matter. Symptoms are mild. Signs are more. This is fungal ulcer. Like BEST, signs are more, symptoms less. Remember points, dry ulcer, rough texture, feathery rolled margins. This is ulcer. This is hypopyon. Satellite lesion is pathogmonic, fixed, hypopyon, non-sterile because fungus can penetrate into the cornea. Satellite lesions, pathogmonic. Symptoms less, signs more. Opposite, young patient comes with soft contact lens, specially washed with tap water, acanthamoeba keratitis. Coming with excruciating pain, ऐसा करोगे तो pain तो होगा ही होगा. But signs are very less. Ring infiltrate, pseudodendrites can be seen. Pseudo, not true. True dendrites are seen in herpes simplex. That is acanthamoeba keratitis. So remember this girl and boy. For Stargardt's and BEST, acanthamoeba, fungus. Both clinical scenarios. Long question will be there, but key words will be there. Satellite lesions will be there. Ring infiltrates, pseudodendrites will be there. It resembles virus. That's why it is pseudodendrites. Because actual virus is a dendritic ulcer. That is herpes simplex dendritic ulcer. You want to give. Topical steroids are contraindicated. That will lead to geographic ulcer. Acyclovir, topical acyclovir is given. Remember, oral acyclovir is also given in all viral keratitis to prevent recurrences. So oral acyclovir also, remember this point. Dystrophies of the cornea is difficult, but please remember stromal dystrophies. If you cannot remember anything, remember 3 dystrophies like this: lattice, granular, macular, and what is deposited and what is a stain. Lattice amyloid, stained by congruent, patho. Granular hyaline, remember meson trichome, this is an important question, can come. Macular is a least common corneal dystrophy, autosomal recessive, Alcian blue stain, mucopolysaccharoid. Granular and macular, remember to differentiate. There are deposits in the cornea, intervening spaces are clear. In macular, the intervening spaces are hazy. This is macular versus granular dystrophy of the cornea. Keratoconus also, expect this 4th question which I am saying, which can come. Keratoconus. A young patient comes with frequent change of glasses. Uniocular diplopia. See the cone of the cornea, it is increasing. So frequent change of glasses. Astigmatism is there. Uniocular diplopia. Famous signs. Fleischer's ring. Iron deposition in the epithelium. Picture won't come. Theoretical question will come. Fleischer's ring. Astigmatism leading to uniocular diplopia. Myopias have it. Munson sign. If the patient looks down, the lower eyelid bulges. Oil droplet reflex, seen on distant direct ophthalmoscopy. U को मान लो V, मानने में क्या जा रहा है? Vertical stria of Descemet's membrane, walked stria. If the Descemet membrane stria rupture, that is known as Hydrops condition. Remember that. And S, we have a scissoring reflex seen on retinoscopy. C3R is a treatment of choice for keratoconus. Which contact lens is given? rigid gas permeable contact lens is a treatment of choice. Toric contact lenses, soft toric contact lenses are given in early keratoconus, but contact lens of choice, RGP contact lens. Treatment of choice, C3R, collagen cross-linking by riboflavin. Can you differentiate the three cornea conditions over here? This is simple. Last NEET question. This is copper deposition in which membrane? Descemet membrane and Cassius-Fleischer's ring, Wilson's disease. Also seen in chalcosis, not pathognomonic of Wilson's. Important point. Starts with superior and inferior, then circumferential. White, calcium deposit like a band in Bowman's membrane or superficial stroma, band-shaped keratopathy, calcification of the cornea. And drugs can deposit in which layer? Epithelium. What drugs? Most common. This is vortex keratopathy, amidron most common. But remember two more, NSAIDs, chloroquine. Chloroquine can come because that is important. It is reversible. Remember, chloroquine, Bowes maculopathy is irreversible. Again, three conjunctiva conditions. Can you remember? Can you know? Three conditions. Pterygium. Many questions have been coming. Pterygium, very easy topic. It is a fibrovascular growth of the conjunctiva coming onto the cornea. Pinguicula resembles a fat. Calcification occurs in pinguicula, not in pterygium. And this is a Bitot spot. Vitamin A deficiency. Vitamin A deficiency, Bitot spot. What do you do for vitamin A deficiency? Prevention, like immunization. Okay, वो pediatrics बताते हैं. 9 doses starting from 1 month. Treatment is important. Why don't know? Why is confusion is there? Treatment is 3 doses, 0, 1 and 14 days, not 28. 0, 1, 14 days. 14th one is a booster dose. Oral dose is usually given. Less than 6 months, 50,000, 6 months to 1 year, 1 lakh, more than 1 year, 2 lakh. You remember intramuscular dose. Don't remember intramuscular. Oral, remember only one. If intramuscular is given, if the child is not able to take oral, do half. Intramuscular is half of oral. Oral is usually, you have to remember. Intramuscular, if comes, half it. It becomes 25, 50 and 1 lakh respectively. Orbit. From the slide, one question definitely should come. A patient comes with proptosis. Rule out pseudoproptosis first, like myopia, contralateral ptosis, eyelid retraction can lead to pseudoproptosis. Pseudo means there is no proptosis, but looks like proptosis, like high myopias, lid retraction. Actual proptosis, most common cause. If the patient has lid lag, extraocular muscle involvement, most common IMSL, inferior, I am so lazy, inferior, medial, superior, lateral, thyroid eye disease. Remember, thyroid levels is not important, it can be seen in euthyroid as well. Most common cause of unilateral and bilateral proptosis. Smoking, important risk factor. Painless, axial, central proptosis, RAPD, relative apparent pupillary defect, always remember optic nerve disorder. In a child, female child, 5 to 10 years, neurofibromatosis 1, optic glioma. But if the same occurs in a female middle-aged, semoma bodies, very important question, meningioma. Alright, optic glioma is the most common ocular manifestation of NF1. Painless axial, gradual vision loss in a female middle age, most common benign intracranial tumor of the orbit, cavernous hemangioma. Schwannoma can also be there, but remember cavernous hemangioma. But if the patient has abaxial, not a central proptosis, painless, look for the direction of proptosis. Like you see here, right eye proptosis going infero-medial. Where should be the tumor? Suprolateral. What is suprolateral? Lacrimal gland tumors. Most common lacrimal gland tumor, pleomorphic adenoma. Painless. Which lacrimal gland tumor will have pain? Adenoid cystic carcinoma. Painful conditions, cellulitis, pseudotumor, malignancy. Differentiate between pseudotumor and thyroid. Extraocular muscle, belly is involved only in thyroid. Here the belly and tendon are also involved in pseudotumors. If all these conditions which I have told you are occurring in the superior orbital fissure, pushing the eye into proptosis, leading to superior orbital fissure syndrome, there will be 3, 4, 6 nerves involvement. Means proptosis plus ophthalmoplegia plus V1, loss of corneal sensations. That is superior orbital fissure syndrome. If any of the causes lead to, along with superior orbital fissure, blindness as well. Second nerve, 2, 3, 4, V1, 6, orbital apex syndrome. These two mostly are unilateral conditions. Any condition, thyroid, anything can cause this, tumor, inflammation. 3, 4, V1, 6, 2, 3, 4, V1, 6. But if the patient has this, pulsatile proptosis, differentials, one very important, one cavernous sinus syndrome. Yes, pulsatile proptosis, Pavitrin, I'm saying. Carotid cavernous fistula, Fracture roof of orbit, dysplasia of sphenoid, meningocele are also cause of pulsatile, but that is transmitted pulsations from the brain. True is keratoco-cavernous fistula. Patient will have, if there is a fistula between ICA and cavernous sinus, patient will have 3, 4, 6, means pulsatile proptosis, ophthalmoplegia, loss of sensation of cornea, V1, loss of sensation of cheeks. That is keratico-cavernous fistula, cavernous sinus syndrome. Pulsatile proptosis. Child having ptosis, absence of eyelid crease, congenital ptosis. Old age having ptosis, high eyelid crease, aponeurotic ptosis. The problem is in aponeurosis. In LPS, aponeurosis is senile. The problem is in LPS, muscle dystrophy. Treatment depends on the mild, moderate, severe. Plicate in mild, resection, make it strong, make it short so that it becomes strong. Severe, very poor LPS action, remember this, frontalis sling, facial lata sling, that's the most important material. Here, the problem is not in the LPS muscle, it's an LPS aponeurosis, so aponeurosis repair. Overall, this is a differentiation between senile ptosis and congenital ptosis. Absence of eyelid crease, high eyelid crease. Poor LPS action, good LPS action. And treatment depends on the condition, aponeurosis repair. Alright, most common cause of ptosis is idiopathic or aponeurotic ptosis. A patient comes with variable ptosis, diplopia, restriction of eyelid movements, ophthalmoplegia, and you do one test, tensile on a rice pack, ptosis improves. Very important, myasthenia gravis. No pain in myasthenia gravis. No pain, no paresthesia, no peas in myasthenia gravis. What is a field defect? Always I told you, whenever there is a field defect like this is how you see. This is the right, this is the left. Right visual field and left visual field, this is a patient's view. What is this? This is left homonymous hemianopia. The question is, where is the lesion? The lesion is in the optic tract. Right optic tract will have left homonymous hemianopia. Optic tract will also lead to which type of pupil? Wernicke's hemianopic pupil. Lastly, NEET question, but an important topic. Next, chiasma lesions are heteronymous. Retrochiasmal are homonymous. Remember this point, heteronymous and homonymous. Retrochiasmal behind, like optic tract, optic chiasma, everything is homonymous. Optic chiasma is heteronymous. Anterior pathway, which is the chiasma and optic tract, they can be incongruous, asymmetrical, can be congruous, symmetrical. As you go behind, they are always, occipital cortex is always congruous. Congruous means symmetrical defects. One example which I am going to give you, optic chiasma lesion, you know this is bitemporal hemianopia. This is heteronymous and it is congruous, symmetrical. Optic chiasma can be congruous also. But here, if there is a anterior junction syndrome of the left eye, left will be total or central loss, other eye will be temporal, supratemporal. So this is incongruous defect. So chiasma can be incongruous, can be congruous, right? But heteronymous, chiasma is always chiasma is mostly heteronymous. Retrochiasmal is homonymous. Homonymous like this. This is right homonymous superior quadrantanomia. Where is the problem? Left temporal lobe is the problem. Pie in the sky. Exact opposite will be parietal lobe. No hang, it is okay. Near pathway, patient comes to you, both eyes are open, a near object comes. Three things can happen. One is convergence, like you see in the figure. Bilateral pupillary constriction can occur, and accommodation. Accommodation means there are changes in the ciliary body which contracts, zonules relax. What are the changes in the lens? That is important. Normally the anterior curvature is 10, posterior curvature is 6. Posterior is more curved. In accommodation, the anterior curvature becomes same as posterior, becomes 6. Means the anterior curvature from 10 becomes 6. Radius of curvature decrease means the anterior lens curvature increase. Horizontal thickness of the lens increase. If horizontal increase, vertical decrease. Equatorial thickness decrease. Anterior chamber becomes shallow because anterior pole is going forward towards the cornea. All these factors are important in accommodation. Remember, posterior capsule, posterior curvature does not change at all in accommodation. Children have very strong accommodation, right? As we go, accommodation decreases, near point goes away. That is presbyopia. Fifth, which I am going to tell you, important question which can be asked is pupil examination. Remember this very carefully. I am giving you a tabular format. A patient comes with anisocoria, difference in the pupil size. Here the left pupil is bigger, this is smaller. But we have to see in light conditions and dark conditions. Anisocoria is more in the bright light. If anisocoria is more in the bright light, it means that the dilated pupil will have the problem. Differentials will be third nerve palsy, AT's pupil, iris sphincter damage, and pharmacological mydriasis. How to differentiate? Do a slit lamp examination and near constriction you have to check. If there is a torn pupillary border, then definitely the answer is damage to the iris sphincter. Test with the pilocarpine dilute, AD's pupil test. If it constricts and tonic constriction, 100% AD's pupil. No constriction, check with 1% pilocarpine, normal pilocarpine. Constriction occurs, it is third nerve palsy. That is a CBD question also. Constriction doesn't occur, it is pharmacological mydriasis. The receptors are full, maybe anticholinergics are given. Remember this table, remember these points for dilated pupil differentials. Similarly, I am going to give you the problem in small pupil differentials, in which the anisocoria is more in the dark light, means the smaller pupil will have a problem. Differentials are Horner's, mechanical meiosis, pharmacological meiosis, or physiological meiosis. How to differentiate? Again, do slit lamp examination. Posterior synechia is there, so it means there is a mechanical meiosis. Posterior synechia, pupil is small. Cocaine test, and there is a dilatation lag. Cocaine for Horner syndrome. If cocaine test there is no lag and there is dilatation with cocaine, it means it is physiological meiosis, because cocaine will not be able to dilate a Horner's pupil. So if there is no dilatation, patient is Horner's. But it cannot differentiate the central, pre and post ganglionic. To differentiate, you have to do amphetamine. If amphetamine dilatation occurs, it means it is before the superior cervical ganglia. It is pre-ganglionic. And if it is no dilatation, then it is a post-ganglionic lesion, because amphetamine works in post-ganglionic pathway. If there is, because it stimulates local nerve endings. In post-ganglionic, no local nerve endings are damaged. So Horner syndrome, post-ganglionic lesion, there is no dilatation on amphetamine. Remember this table for smaller pupils. Remember the previous table for dilated pupils. Expect one question out of these tables. Glaucoma management is very important. If the gonioscopy angle is open, IOP is normal, it means you have to check optic disc. If normal, everything normal, then patient is normal. Normal bhi insan hote hain. But if there is changes in the optic disc or the visual field, you call it normal tension glaucoma. IOP high, open angle, check optic disc. Optic disc is changes, primary open angle glaucoma. Only when there is optic disc visual field changes, you can call the patient glaucoma. Otherwise, you cannot call the patient glaucoma. Why? Because if optic disc is normal, you call ocular hypertension. NTG, POG, there is glaucoma, you have to start the treatment, medical management followed by laser trabeculoplasty. To defer the surgery, trabeculectomy, this is the gradation. Ocular hypertension, usually in your conditions, in your stage, mostly answer will be observation. Unless and until the cornea is very thin, IOP is more than 30, myopia, and changes in the some pattern standard deviation changes in the visual field, then you treat. But most in your at your level, the answer of OST will be observation. Similarly, closed angle definition is important. Closed angle on gonioscopy, IOP is normal. Check the optic disc visual field, that is also normal. PSES. IOP high, closed angle IOP high, check optic disc, normal. PSC, same as ocular hypertension of open angle, primary angle closure. And changes are there, it is glaucoma. All the three, laser iridotomy first, because the anatomical risk factors make a hole in the iris. If that doesn't work, start with medical management. If there is a glaucoma or high IOP, if that doesn't work, surgery, trabeculectomy has to be done. Acute congestive glaucoma, remember this point. Acute congestive glaucoma, which is also known as acute angle closure, can be seen on any of these three. And for that, that's an emergency situation. IOP goes very high, 60, 70. For that, immediately lowering of IOP has to be done by mannitol or astazolamide. Treatment of choice for that condition will also be laser iridotomy. But initial drug to be given is mannitol or astazolamide in acute congestive glaucoma. Otherwise, for POAG, NTG, PACG, the drug of choice or the first drug we started is prostaglandins. Okay, I hope it is clear now. Best is Goldman application tonometer. Tonopen based on application principle. Tonopen particularly done for corneal opacities, irregular corneal surfaces. Self tonometer, patient can use his check his own IOP by rebound tonometer. A child with big eyes, watering, photophobia, symptom triad, blepharospasm. Signs with big eyes, ophthalmos, HAB stria, Vox stria in keratoconus, HAB stria in congenital glaucoma, horizontal stria, Desmond membrane stria. Deep anterior chamber, this is nothing but congenital glaucoma. Surgery has to be done, goniotomy has to be done, not trabeculectomy. Goniotomy has to be done. If the cornea is hazy, then trabeculotomy. But if the option has goniotomy plus if the option has trabeculectomy plus trabeculotomy, that will be a better answer than goniotomy. If A, B, C, D, 4 surgeries are given, goniotomy is the treatment of surgery of choice. If in one option and combination can be only of trabeculectomy plus trabeculotomy, that is a better answer than goniotomy. All right. Always remember this cross and squint. Superior rectus is here because it is a maximum elevator in the abducted position. Which muscle is the maximum depressor in abducted position? IR. So always remember this cross. IO is the maximum elevator in adducted position. Don't confuse with the theoretical. Theoretical, superiors are in tortus, recti are reductors, that is theoretical. Remember this cross because which muscle is again elevator in abducted position? Superior rectus, and so on. If two eyes are working together, both eyes are primary position looking straight. Which muscles are working in this dextroversion? Right LR muscle is working, left MR. Which muscle is working in levoversion? Again, yoke muscles, corresponding muscles are working in the positions of gaze. Dextro elevation, right SR and corresponding left IO. All are yoke muscles of each other. Similarly, levo elevation, dextro depression, right IR, left SO. So cross is very, very important. These are Herring's law. And nerves also remember, SO4, LR6, less by 3. Because that will determine the conditions like this. Right eye looking straight, left eye going inside. What is that? That is left LR palsy, left esotropia. Patient will come with horizontal diplopia only. And just check the, I told you, I always say, just check the muscle. This left LR is working on the left side, so horizontal diplopia is maximum on the left side, on looking left. Compensatory position is also on the left side. Only horizontal diplopia, compensation only in horizontal diplopia is face turn. Just look at the muscle, that will give you the diplopia also, that will give you the face turn and chin up down also. This patient, right eye looking straight, left eye going up. What is that? Left hypertropia. If left is going up, right is down. Left hyper equal to right hypotropia. Question is, it is increasing, diplopia increasing on looking right and diplopia is increasing on looking left. What is the muscle palsy? Increasing on looking right, increasing on left head tilt. How to solve? The Park 3-step test. Left hypertropia means left depressors might not be working. Or right hypotropia means right elevators not be working. Answer is between these 4 muscles. Increasing on looking right, just choose the right side muscles out of these 4. What is the right side? Right SR, left SO. Increasing on left head tilt. Remember, superiors come with. Increasing on left head tilt means he will come with left head tilt or right head tilt. He will come with right head tilt. Increasing, diplopia increasing on left head tilt means he will come to you with right head tilt. So here the patient is coming with right head tilt. Superiors, remember, superiors come with opposite head tilt. Right SR palsy come with left head tilt. Left SO palsy come with right head tilt. This patient is coming with right head tilt, left SO palsy. Only one muscle will be satisfied. Park 3-step test. Left eye looking straight, right eye looking right, esotropia. This is the primary, this is the normal. Normal is fixating, so it is, for example, deviation is 30. If the squinting eye is fixating, it is 45-degree deviation, primary and secondary deviation. Primary means normal fixating, secondary means squinting eye fixating. Secondary deviation is more than primary deviation. So what type of squint? That is the question. Is it comitant or incomitant? Incomitant. Can be paralytic, can be restrictive. And what is the condition here? It is a right esotropia. That is important. That is left is normal, right is esotropia. right, straight, left, down and out. Remember down and out, don't confuse in third nerve palsy. Third nerve supplies LPS, ptosis. So hypotropia, exotropia. Diplopia in all the positions except down and out. Pupil is dilated because third nerve supplies the efferent of the pupil. Direct consensual reflex also absent in third nerve palsy. Diplopia in all the direction except down and out. Remember this, down and out, down and out, down and out for third nerve palsy. Another sixth question which I am saying which can come is one of these: third nerve, sixth nerve and fourth nerve palsy, or the question based on that. Patient has horizontal binocular diplopia, can be crossed, can be uncrossed. Cross, exo has cross, foria, tropia, cross diplopia, ESO has uncrossed diplopia. You can check it by Maddox rod. The question is, patient in right eye, Maddox rod is horizontally kept. If he sees like this interpretation is a patient's view, like visual field. Dot in the center, patient is normal. But if the patient sees like this is because of the line, is because of the right eye, Maddox rod in the right eye, vertical line. This is right, interpretation is like this. Please remember, right is over here, left is over here. In patient's view, your view, this is crossed, uncrossed. This is uncrossed, esophoria, esotropia. You cannot differentiate esophoria and tropia. This is ESO. If the patient sees like this, remember like this, it is on the opposite side. Opposite side is crossed. This is exo. Quick questions. This is emetropia. What is the far point of emetropia? Mars tak dekh sakta hai, infinity tak. Far point is infinity. Hypermetropia. Far point infinity to infinity. Imaginary. Imaginary questions are not asked. Behind the eye. Myopia question will be asked. Myopia is in front of eye. To change the myopia power into meter, reverse it. Means far point means how much you can see in front? 50 centimeter in front of eye. Half meter, mass achhi hai, 50 centimeter. What is the far point of -4 diopter? 1/4 meter, 25 centimeter in front of eye. That is the far point. Near point I told you, because of accommodation. As children have very strong accommodation, they can read the books very close. But as we age, friends increase, books decrease. Books goes away, 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 away. What is that? Presbyopia. After 40 years, it usually develops. What is the refractive error over here? I tell you, this is horizontal, this is vertical. If vertical steeper, it is with the rule. Horizontal steeper, it is against the rule. How to know which is steeper? Check the more myopic axis. Myopic means either refractive error. +1 is more myopic or +4. So both are hypermetropic. But in comparison, +1 will be more myopic. Means it is compound hypermetropic astigmatism against the rule. Both are plus means both are away from the behind the retina. +1 will be closer to the retina. +4 will be away. So +1 is more myopic. More myopic is more steeper axis. Compound hypermetropic against the rule is the answer. Similarly, -4, -6, both are in front, different points. Compound myopic astigmatism. -6 is more myopic, again against the rule. What is this? 0, -4. 0 means rays on the retina. Minus is rays in front of retina. Simple myopic astigmatism. Vertical is steeper with the rule. So more myopic axis in the refractive error. You get confused over here. This is keratometry power. 44 diopter, 47. Have you seen any patient having 44 diopters chashma? This is keratometry. That is straight away cornea power. Normal cornea power 44. More the cornea power is more myopic axis. More cornea power, rays is more converged, means more myopic, more steeper. So this is vertical will be more steeper over here. 47 is more steeper than 44. So this is only you have to tell which axis is steeper and which rule. Vertical steeper with the rule. So here it is keratometry, not refractive error. How to convert this into the refractive, the cross? +2, +2 is working in both axes. Sphere works in both axes. Cylinder is kept at 90 degree, but it will work in the 90 degree opposite. Horizontal it will work because it is kept at 90. So +2 and +1 becomes compound hypermetropic astigmatism. +1 is more myopic against the rule. This is to convert the equation into the cross formulation. If you want to leave one topic in eye, very big topic, leave uveitis. But some point, one quick point of systemic condition they can ask in a young patient, HLA-B27. Remember the systemic scenarios of psoriasis, rectus and ankylosing spondylitis. That is HLA-B27. Juvenile idiopathic is silent uveitis, less symptom in the child. While Behçet's clinical condition, it is also all a non-granulomatous condition. Non-granulomatous means lymphocytes will be there and KPs are small, fine KPs. Granulomatous will have large mutton fat KPs. But uveitis, one condition, remember, because this is related to trauma. Trauma, one question will definitely going to come, I think. Penetrating trauma leading to recognition of the retinal antigen by the eye. It leads to granulomatous uveitis in both eyes. This due to trauma, this due to type 4 hypersensitivity reaction. Both have panuveitis, granulomatous panuveitis. That is sympathizing. Why? Because this is exciting eye. Other does not have trauma. You have sympathy, sympathizing eye. Critical period 2 weeks to 3 months. Development of sympathizing eye. First symptom, loss of accommodation. Retrolental flare is first sign. Treatment is intravenous steroids. We don't take out the eye nowadays. Intravenous steroid. Try to save the eye. Dielenphic nodules are under the retina. That is also seen in Vogt-Kyenge-Harada syndrome and sympathetic ophthalmitis both. So remember the sympathetic ophthalmia in uveitis if you want to remember one point in uveitis. Lastly, very quickly, Snellen's chart. What you have to remember? Minimal angle of resolution. Just reverse the visual acuity. Only MAR is asked. Just reverse visual acuity. 10 minutes, 6:36. Reverse 36 by 6 minutes, 6 by 6, 1 minute. But if the total, this is from one segment, each segment, there are 5 segments in each letter. So if the total letter subtending angle in the eye is asked, how much the total angle subtends? The 6 by 60, 5 segments are there in each letter, multiplied by 5, so 50, 30, it becomes 5. Only MAR is asked, just reverse the visual acuity. Total letter subtend is asked, multiply by 5, the minimal angle of resolution, that is, and smaller the minimal angle of resolution, better is the vision of the patient. Right eye to be seen by the right eye, uniocular test, direct ophthalmoscopy. Binocular test, stereopsis, to see the entire retina, fundoscopy. Here you see only the optic disc and macula. Here you see the entire retina. If entire retina is seen, the field of view is more. Field of view is more in indirect ophthalmoscopy, but real inverted image is seen. Here, erect image is seen. Magnification, it is like a simple magnifier at your home. Power of the patient's eye, not doctor's, power of the patient's eye divided by 4. Emmetropic power take at 60 if it is not given. Here, there are lenses in the doctor's hand. Power of the eye divided by the power of the condensing lens used. The condensing lens in the doctor's hand can be 20 diopter, 30 diopter, that will be given to you. The image is real inverted form between the doctor and the condensing lens over here. Real inverted image is between the doctor and the condensing lens. Retina is real inverted image. Magnification of an emmetropic eye in direct ophthalmoscopy is 60 by 4. Maths अच्छी है भाई 15 times. But magnification in the myopic. Myopic has more converging power, means more power than 60. Minus 4 myopia means the power of the eye will be 60 plus 4. 64 divided by 4, 16 time will be the magnification. Myopia has more power than emmetropia, which has more power than hypermetropia. If you have plus 2 spectacles, means your eye power is 60 minus 2, 58 diopters. That is why it is diverging behind the retina. So more power myopia, then emmetropia, then hypermetropia, and you can calculate the formulas of direct and indirect ophthalmoscope. I think that will be all from my side. ये मैं हूं, ये तुम हो सकते हो. Always remain happy. ये मैं हूं, ये तुम हो, और हम आपको best wishes दे रहे हैं. Thank you very much. Thank you very much. Thanks a lot. You can ask any questions. This very small session I have told you, and you can ask me questions on any of these platforms, on the club, anywhere. Best wishes from my side.